Welcome back to our research spotlight. Today we are discussing a 2026 prospective cohort study that examined whether children born very preterm with very low birth weight show differences in body composition and insulin resistance by preschool age. Preterm birth is not only a concern during the neonatal period. Increasing evidence suggests that being born early may influence long-term cardiometabolic health, including risks related to insulin resistance, obesity, hypertension, and metabolic syndrome. One important question is whether these risks are already visible before school age. This study focused on children aged 5 to 6 years who were born before 33 weeks of gestation and had very low birth weight. The researchers compared them with term-born children of similar age. The main goal was to determine whether preterm children had altered body composition, such as higher fat mass or lower lean mass, and whether they showed evidence of insulin resistance. To answer this, the researchers used dual-energy X-ray absorptiometry, which is a reliable method for measuring body composition. They measured lean mass index, fat mass index, trunk fat percentage, and total body fat percentage. They also collected fasting blood samples to measure glucose, insulin, and lipids. Insulin resistance was estimated using HOMA-IR, which is calculated from fasting glucose and insulin. The study included 96 children in total, 57 preterm children, and 39 term-born controls. So what did they find? Interestingly, the preterm children did not show major differences in DXA-derived body composition compared with term-born children. Lean mass index, fat mass index, trunk fat percentage, and total body fat percentage were generally comparable after adjustment for age and sex. However, there was an important metabolic difference. The preterm children had significantly higher fasting insulin levels and higher HOMA-IR values than the term-born controls. This means that even though their body composition looked similar, their metabolic profile suggested reduced insulin sensitivity. This finding remained present even when the researchers looked only at preterm children with normal weight. In other words, higher insulin resistance markers were not explained only by overweight or obesity. The researchers then looked within the preterm group and divided children into BMI categories: underweight, normal weight, and overweight or obesity. Here the pattern was clearer. Preterm children with overweight or obesity had higher trunk fat percentage, higher total body fat percentage, higher fat mass index, higher fasting insulin, and higher HOMA-IR compared with normal weight and underweight preterm children. This suggests that among children born preterm, excess weight at preschool age may be particularly important for metabolic risk. Another key finding involved growth timing. The researchers examined weight gain during different developmental periods. Weight gain from 2 years to 5 to 6 years was positively associated with trunk fat, total body fat, fasting insulin, and HOMA-IR. Earlier growth periods were not strongly associated with these outcomes. This is important because it suggests that later early childhood weight gain, not only neonatal catch-up growth, may influence adiposity and metabolic health in children born preterm. The study also reported sex differences. Girls had higher trunk fat and total body fat percentages than boys in both the term and preterm groups. However, insulin resistance markers did not differ significantly by sex. The authors also examined small for gestational age status. Preterm children born small for gestational age had lower weight, height, BMI z-scores, and lower fat distribution measures, but they did not show significant differences in insulin resistance. So, what is the main message of this study? The key takeaway is that children born very preterm with very low birth weight may already show early metabolic alterations by preschool age, even when their overall body composition appears similar to that of term-born peers. This does not mean these children have clinical diabetes or overt metabolic disease. The authors note that insulin and HOMA-IR values were still within the accepted normal range for preschool-aged children. However, the higher values may represent early signs of altered metabolic regulation. Clinically, this study supports the idea that Long-term follow-up of preterm infants should go beyond simple measurements of weight and height. Monitoring metabolic health, growth patterns, and body composition may help identify children at increased risk earlier. The findings also suggest that nutritional and growth management should aim for adequate growth without excessive weight gain, especially during early childhood. Like all studies, there are limitations. This was a single-center study with a relatively small sample size, especially in the overweight and obesity subgroup. The control group included only term-born children with normal BMI, which may limit generalizability. Also, follow-up was limited to preschool age, so longer studies are needed to determine whether these early metabolic differences persist into adolescence or adulthood. In conclusion, this paper highlights an important point. Preterm birth may leave a metabolic signature that appears before obvious differences in body composition. For children born very preterm, especially those gaining weight rapidly between 2 and 6 years of age, early monitoring and preventive care may be important for reducing future cardiometabolic risk. Thank you for listening to this research spotlight. Today's paper reminds us that survival after preterm birth is only the beginning. The long-term quality of growth and metabolic health also matter.